Good afternoon, everyone, and welcome to our Small Bites event. Today, we are talking about Know Your Numbers, and our original speaker, Dr. Stern, had to go out of town. And so today, we are happy to welcome Dr. Brown. Thank you for joining us, Dr. Brown.
Hi, everyone. Thanks for having me. Hi, Kristen.
A little bit about Dr. Brown. Dr. Brown is the Director of Inpatient Cardiac Services, Northwell Health, Lenox Hill Hospital. She is the Northwell Health Lenox Hill Hospital Site Director for multiple heart failure clinical trials, and she completed the Six Sigma DMAIC program as a black belt. That's amazing. Applying for expertise to various cardiology quality improvement projects. She is the chair of the New York American College of Cardiology Diversity, Equity, and Inclusion Task Force, responsible for defining and carrying out the mission of the program, which is to develop and sustain a culture which educates, supports, and celebrates diversity while actively providing mentorship opportunities to underrepresented persons in medicine. Additionally, Dr. Brown is an ambassador for the American Heart Association, giving frequent educational talks on diversity, health equity, and women's health. And she serves on the board of the AHA STEM committee as an executive leader. So welcome, Dr. Brown. And if anyone would like to post some questions in the chat, we will be taking those at the end. And with that, I will turn it over to Dr. Brown. Thank you again for joining us.
Thank you, Kristen. Thank you, everyone, for coming. I'm just going to jump right into it because we have a lot to go through, but I do want to leave time at the end for comments and questions. So without further ado, we'll be jumping into definitions, talking about risk factors, and then going through what the American Heart Association deems as the numbers you absolutely need to know, not only in the clinic, but at home. So the first is the definition of cardiovascular disease. What does this mean? So there are certain disease states that fall under the category of blood vessel and heart disorders, and those are listed on your screen. So for example, that's heart disease that includes the arteries, so that's heart attack, and the arteries are blocked. You'll see pictures later in this program that show a pictorial of how plaque deposits within the arteries of the heart and cause blockages of blood, oxygen, and nutrients to your heart muscle tissue. Also high blood pressure. The same concept of the artery blockages in the heart can apply to the legs and the trunk, and that's called the peripheral artery disease pathology. And then you have diseases of the blood vessels of the head and neck, and that can cause a stroke or a TIA, which we will definitely get into in a few slides. You also see congestive heart failure here, valve disease, and arrhythmias. All of these are examples of disorders of the heart and the blood vessel system. So what is the impact in the United States? As you can see here, it's quite significant. It's not just in the United States, it is across the globe. It is the leading cause of death in the Americas and across the world. Heart disease, so artery disease of the heart, is the most common type. Right, 18.2 million adults 20 years or older have artery disease of the heart. And this is not the disease of the grandma, grandpa anymore. I have 30-year-olds currently on my service in the hospital with artery disease of the heart, with heart failure, with valve disease, with artery disease of the legs and the aorta. So this is of a younger and younger demographic. 2 in 10 deaths from artery disease of the heart are in adults under the age of 65, as you see here. So that means every 40 seconds, that's longer. I took longer to say this slide than it did for someone in the United States to have a heart attack. So every 40 seconds, so that's almost 1 million persons a year. What factors increase your risk after hearing all of that danger information? Right? What factors increase your risk? So the things to look out for, the diagnoses to look out for when you're going for your semi-annual or annual screenings, that's obesity, high blood pressure, diabetes, artery disease of these vessels in the neck we call carotid arteries, and peripheral artery disease. Those are the diseases of clogged arteries in the legs and in the trunk area. So what we call celiac arteries, femoral arteries, aorta. That's peripheral artery disease, blood cholesterol being elevated, as well as smoking and not exercising. These are all risks that increase the potential of having a major coronary event over the next 10 years of your life. So I know there are a lot of women on the call. I did not want to exclude disparities among women in this talk, because I think it's very important to note that over the past few decades, there have been strides, but there's still more work to be done to decrease that gap and reduce heart health disparities among women. So heart attacks are misdiagnosed more often in women than in men. Well, you say, why is that? That's because women in part are less likely to be prescribed heart medications, appropriate heart medications, than are men. The incidence of cardiovascular disease in women is lower, but women have more complications, I should say, or worse prognosis after they've had a heart event. Also, women are more likely to report that they have a poor relationship, poor satisfaction, and poor communication with their healthcare provider. So how can we address these disparities? It's education, education, education. Then access, access, access. And then we have community liaisons, ethnically intuitive nutrition programs, gestational screening, treatment of reproductive endocrine disorders. What do I mean by that? For example, PCOS, polycystic ovarian syndrome. That has implications on cholesterol and blood pressure. So you may know you have PCOS, but are you and your doctor in partnership to treat the downstream effects of that? Perimenopausal and postmenopausal related risk factors. So as I stress to my patients, menopause is not a disease. It is a natural course of life. So we should not be treating menopause as if it's a disease. We should be recognizing that menopause can impact certain heart disease states, such as cholesterol and high blood pressure. So you can have increased LDL, which we'll talk about in a few slides, as low density lipids. It's a type of bad cholesterol. And as estrogen declines, you have an increase in your resting blood pressure levels as well. So these things should continue to be screened for cholesterol disorders, blood pressure disorders, as you go through the peri and postmenopausal period. In addition to recognition of what we call non-traditional cardiac symptoms in women. They used to be called atypical symptoms, but we are now going far, far away from that term and recognizing that these are in fact quite typical symptoms in women, but they may be non-traditional, but they are just as important to recognize. So now getting into a couple of meanings. Meanings in particular for two major cardiovascular events, the first being a heart attack. So what does this mean? I alluded to it before when I was going through the definitions of cardiovascular disease. So what is a heart attack specifically? As you can see in the pictorial, it's when plaque, so that's formed by fat, cholesterol, and other substances, build up within the interior, within inside of the walls of your heart arteries. That plaque piece can then break off and then a clot forms. So if you can see, I'll give a little wiggle with my arrow here, right? That purplish or pinkish discoloration you see, this is the clot, right? That then blocks blood flow completely. And when blood flow is cut off to your heart muscle tissue, it is then starved of blood, oxygen, and nutrients. That muscle tissue starts to die. Once that's tissue is dead and gone, we cannot bring it back, and that's called an infarction of the heart muscle tissue, myocardial infarction. So we want to prevent blockage of blood, oxygen, and nutrients so that your tissue does not die off, and we can preserve pumping function and not have bad outcomes such as heart failure. So what is a stroke? A stroke, very similar concept. So we're talking about the blood vessels within the neck and brain. And so that's when the same material, plaque, cholesterol deposits, clog up those blood vessels, that highway system, and it cuts off oxygen, blood, and nutrients that's going to the brain. Another version of stroke is when you have that blood vessel burst, tear, or break open. And so blood then seeps out of that vessel and onto the brain tissue. So that first type of stroke that I was talking about, caused by a blockage of a blood vessel within the brain, that is called an ischemic stroke. When the blood vessel tears or rips open and the blood seeps out of that torn vessel, that's called a hemorrhagic stroke. By far, ischemic strokes are more common. It's almost 90% of all strokes, but hemorrhagic strokes are much more common among uncontrolled hypertensive patients. Again, same concept with a heart attack. When you cut off blood, oxygen, and nutrients to tissue, that tissue starts to die. So you can imagine, same thing as with the heart and having a myocardial infarction. If you cut off blood, oxygen, and nutrients to the brain tissue, that leads to dead brain cells. And once those tissues have died and you see an infarcted area in the brain, that tissue does not come back. What do we mean by a TIA? And this is commonly known colloquially as a transient ischemic attack mini stroke. Mini stroke, you've probably heard more often than transient ischemic attack. So what does this mean? The definition is in the wording. So transient comes and goes. And unfortunately, this means that the symptoms may be under-recognized, underappreciated, and underreported. And that seeking help or calling 911 is much less common in persons who are having a TIA and those who witness someone having a TIA. So what does this mean definition-wise? That means you have a temporary blockage. Can everyone see in presentation mode? Oh. Are we having technical difficulties? If I can have feedback from the audience?
Yeah, it looks like we're seeing your full screen right now with all of your
Yes.
slides.
And then nothing is moving, yes? So can I have backup, please? Oh, and I see the blue circle of death. So not a good sign. All right, so I'll stop sharing. And I can talk about transient ischemic attack while we pull up my backup slides. So transient ischemic attack is essentially when you have a temporary blockage of blood flow to the brain. So you have that piece of plaque that forms, and there may be a clot there, and the body can break it down and resorb it. And so you have establishment of blood flow returning to the brain. So blood flow is cut off, then it returns, cut off, then it returns. So you may have temporary signs or symptoms of a stroke. So you may have slurred speech that comes and then clears up. You may have arm weakness that comes and then you have full strength in your arm. That's an example of transient signs and symptoms that's related to a blockage that is temporary. So this is a transient ischemic attack. We are going to go to the slide that's called Know Your Symptoms. Next. And when you have that up, please let me know.
Hi, if you could just go through that slide and then we'll pull up the next one where we're currently loading the deck. Thank you. Thanks, Dr. Brown.
No problem. So I can talk through it, just like I'm talking to my patient 10 minutes ago. But a heart attack, so we'll talk about the general presentation of a heart attack that are across the board common in men and women. So the most common sign or symptom of a heart attack is chest pain. Some people may describe it as crushing or squeezing, tightness, sharp, somebody stabbing me in the chest, or an elephant is sitting on my chest. Those are very common symptom descriptions across men and women. For women in particular, you may feel what used to be called atypical symptoms, but as I said before, these are recognized increasingly so as more common symptoms in women. So these are sweating, fatigue that's out of proportion to normal, right? You used to be able to make your bed, brush your teeth, take a shower, get all the lunches ready and cook the dinner, and now you can barely pull the sheets over the bed. You can't bathe yourself. You get short of breath, winded, and sweaty while you're trying to dress yourself. That's not typical, right? And that's not fatigue due to working a long day. That's not fatigue due to taking care of small children, right? That's fatigue out of proportion to normal activities of daily living. You may feel what we call gastric colic, so upset stomach, a little nausea, sometimes vomiting, and that is more typical in women. There's also symptoms of lightheadedness or dizziness, and that is, again, more common in women than in men. but the most common across genders is the chest pain syndrome. Now, getting into stroke, the symptoms of stroke can be learned by the acronym BFAST. The easiest acronym to memorize is FAST, which is F-A-S-T, but BFAST will help capture more stroke patients, whether you're screening yourself or whether you're screening someone else. So BFAST, and you want to look at balance, eyes, face, thank you very much, technical support team with the backup slides, arm, and speech and time. The T for time is calling 911, if those slides can go back up on the screen. But for example, balance. If you no longer are able to walk well, you're off kilter, your eyes, you have sudden blurriness or decreased vision. It doesn't have to be both eyes. It could just be one eye. Some patients have described it to me as a curtain or a shade coming down over one of their eyes. With regard to their face, right, I have seen in patients, and some people have seen in themselves by looking in the mirror and self-diagnosed, that their lip is a little droopy or their eye is a little droopy, right? And that's not just our usual asymmetry that we were born with from birth, right? This is different, right? That is facial asymmetry, okay? That's not usual. If you were not born like that and you wake up like that, do not dismiss it, don't discount it, don't write it off and say, I'm tired, I'm stressed, I've had a long day. Please don't. Time is tissue. Don't waste the time necessarily to get to your diagnosis and get to treatment and resolve that stroke, potential stroke. The additional things you need to know about arm. So I usually drink coffee in the morning, right? I can pick up that coffee mug and it's not hard for me. But today I dropped the cup. Today I can't grip the cup. Today I can't feel the cup. That is not normal, right? S for speech. So far, I hope I've been articulate and everybody can understand what I'm saying, but if it's not this, let's call love speech. And if anybody stopped and said, what did she just say? That's perfect, because you just diagnosed me with garbled speech, right? That is not normal. So we want to make sure we are looking for these signs and symptoms, both in others and potentially in yourself, hopefully never. And the T stands for time. That's don't waste the time, don't spend the time looking up anything on the internet, calling a friend, texting a coworker, right, in order to self-diagnose, because again, time is tissue. So when it pertains to any heart pains or symptoms, gastric colic, sudden sweatiness, lightheadedness or dizziness, feeling like you're going to pass out, or stroke symptoms, that time starts ticking, right? Because potentially your heart muscle tissue or your brain tissue is being starved of blood, oxygen, and nutrients. Oh, fantastic. All right, so next slide. Oh, I see hand claps. All right, so this is a wonderful segue. So how do you arm yourself? So how do you arm yourself with the tools to prepare yourself for your annual physical, to prepare yourself if you have high blood pressure or high cholesterol or diabetes, any of those risk factors? How do you arm yourself with the tools that you need to know in order to control your risk factors, to reduce your risk for having a brain or a heart event? And that's by knowing your numbers. So getting into the numbers, right, I won't spend too much time on the body mass index, because I think too much time, honestly, this is my opinion as a cardiologist, too much time is spent on the number and not what the number implies, right? So we focus on, oh, I'm in the obese category, I'm in the overweight category. Right. What I want to emphasize is that the BMI stands for how much weight you are carrying for your body frame, and both over and under BMIs are equally as detrimental to your health. We know through research that carrying too few weight, right, too little weight for your frame has implications on nutritional deficiencies, particularly iron deficiency. It also has implications in bone density, osteopenia, osteoporosis, bone fractures, etc. And carrying too much weight for your frame, meaning height, that has implications in heart health, brain health, kidney health, diabetes risk, and also lately, as it pertains to the pandemic, COVID-19 outcomes and morbidity and mortality. Next slide, please. The next numbers to know are blood cholesterol numbers. Now you may say, I mean, I know blood cholesterol, but what are all these LDL, HDL, and then if you've seen TG, right, that stands for triglycerides, what are all these acronyms on the screen? Well, the key thing to know is that there's some good cholesterol and there's some bad cholesterol. So the total cholesterol should be under 200, and that's for general all comers, right? And I'll make a little side comment about if you already have heart disease, if you know you have that, if you already have high cholesterol and you're on medication, what should your new goals be? That's not posted on this screen. But LDL, think of it as peanut butter, right? LDL, slow, sticky, right? It attaches very easily to the insides of your blood vessels and it contributes to plaque formation. So it just layers up and forms that nice chunky buildup. So think of it as some Skippy inside of your blood vessels. You don't want that, right? Who wants peanut butter inside of the blood vessels? You want bowling balls, right? Nice marbles rolling along, right? And that's your HDL. So the LDL, you can contribute to that, right? And we don't want to contribute to that. We can contribute to that by lots of red meats, processed foods, and things that are high in cholesterol. So if you turn the package over, things, saturated fats, my family loves butter. We come from a butter loving, chef heavy family, right? That will contribute to my LDL, right? So I have to make sure, right, that I don't inherit that trait of the heavy hand with the butter dish. So that's one example. Red meat, so beef, lamb, for example, and if anybody eats game, so gamey meats or higher in cholesterol. So think if you want to substitute that out, fishes, turkey, and chicken. HDL, you can contribute to raising your HDL because we want that cholesterol that starts with an H to be high. That's how I teach my patients to remember that. You want it to be high. It's like that rolling marble, right? Rolls along. HDL, you increase that by exercising, right? That's one of the ways. Exercising, and omega-3 fatty acids, fishes have that, nuts have that, and triglycerides, if we can post those slides back to the screen, triglycerides are increased particularly with sugary foods. So if you have things like cookies, candies, cakes, alcohol is a big one. It has lots of hidden sugars, but alcohol will increase your triglycerides. And we also see high triglyceride levels in our diabetes patients because with diabetes, as we'll get into the next slide, you have blood sugar literally, physically attached to your hemoglobin, your red blood cell. So after blood cholesterol, I believe, was it blood sugar? Well, sure, we'll go to blood sugar. So blood sugar, norming, I meant to say, right, so for those who have high cholesterol and are on medications, and for those who have heart disease, right, your LDL goal, I'm just going to give you this tip and trick as a cardiologist, your LDL goal should be under 70. That's your new goal, not 100. It should be under 70. And why is that? That's to help reduce your risk. If you've already had a heart attack, if you already have a stent in a heart artery to open up a blockage, this is called secondary prevention. So you've already had an event. What do we do to prevent a future event, right? And we want to decrease that low density, that peanut butter lipid, as low as we can, under 70. Next slide, please. That should be, I believe, blood sugar. So for blood sugar, fasting blood sugar should be under 100. When you wake up in the morning and you check your finger stick, it should be under 100 fasting, unless you're a nighttime snacker, right? And you wake up in the middle of the night, whether known or unknown, sleepwalking or not, and you have a peanut butter sandwich, you have a drink of milk, you have a cookie, perhaps, in the middle of the night. If you're not doing any of that, your fasting sugar should be under 100. And we have some risk profiles up on the board, but if you do have diabetes and you're on medication, your goal hemoglobin A1C should be less than 7. So what is a hemoglobin A1C exactly? So hemoglobin, red blood cell, carries oxygen and deposits it to your tissues around your body. Sugar attaches to that hemoglobin molecule. And what we're measuring when we test a hemoglobin A1C is how saturated are those hemoglobin cells with sugar. So when I say it is literally, not figuratively, but literally, attachment of blood sugar to your red blood cell, that is exactly what it is. And the life cycle of a red blood cell is about 90 days, which is 3 months. So that's why your hemoglobin A1C, if you're on treatment and actively trying to reduce that number, a good frame in which you work to retest that hemoglobin A1C should be, if you want to check, 3 months, 4 months, 6 months, right? In that interval, 3 months, 6 months, 9 months, 12 months, right? Because if you test when you still have the same circulating red blood cell, right, we don't want to test too soon. So every 3 months, or more. So that goal should be less than 7, fasting sugar under 100. Next slide, please. The other way. Thank you so much. I believe it's blood pressure time. So blood pressure, if anybody has a cuff at home, fantastic. I love that, right? I believe everybody should have a blood pressure cuff at home, because what is the issue with going to your primary care doctor once a year? Well, once a year, you know your blood pressure. Unless, right, you're checking it at home, or unless you're checking it at the CVS or the Walgreens or the Walmart, whatever place has that public blood pressure cuff. And we're probably a little more squeamish about using public things nowadays with, various pandemics going on, monkeypox and COVID-19, etc. So unless you have alcohol wipes and Clorox bleach wipes in your pocketbook or your backpacks, right, which many of us probably do now, and you're wiping down those public blood pressure cuffs, we're probably not checking our blood pressure very often, right? So what I would advocate for is that you either get a blood pressure cuff or find a place where you can frequently check your blood pressure. So what should your numbers be? What is a normal blood pressure to a cardiologist based on the guidelines? So as you can see here on your screen, it's probably a number that you would have thought was too low, or maybe you thought it would be in the 130s or the 140s. So it's actually under 120 on the top and under 80 on the bottom. That's a normal blood pressure. Nice and cool, 115 over 75. Perfect, right? I love those numbers. Why? Because that protects your brain, your heart, your kidneys, your liver from excess pressure. When your end organs, such as the ones I mentioned, are feeling such high pressure, let's say 180 over 110, they start to stiffen, right? And those stiff arteries, right, they get inflamed, and that inflammation draws cells that deposit, and then you increase the rate of blockage formation. So you can imagine if you have high blood pressure for years on end, you can increase the rate of plaque deposit in your head, your neck, the arteries of your heart, even your kidneys. And that leads to potentially stroke, heart attack, and kidney disease, and ultimately dialysis, which is end-stage kidney disease. So what do we classify as hypertension, right? And there's multiple stages of hypertension, which I won't get into, but what is hypertension? It's over 130 on the top and over 90 on the bottom. And I keep saying top and bottom. So what are the formal names for top and bottom? The formal name for the top is systolic blood pressure. The formal name for the bottom is diastolic blood pressure. So, well, what does that mean? Systolic blood pressure, every time your heart contracts, right, that generates force, and the blood pressure that your arteries, every artery in your body is feeling when your heart is contracting is your systolic blood pressure. The bottom number, diastolic blood pressure, is when your heart is relaxed or when it's supposed to be relaxed. So can you imagine if that bottom number is 110, 120, even 90, right? The blood vessels all over your body are feeling elevated pressure even when they're supposed to be relaxed. So you can imagine how constant high blood pressure, both systolic and diastolic, can affect your entire body. Next slide, please. What affects my numbers? So we're going to get into a few food groups. So it's the sneaky S's, I call them: sodium, sugar, right? So sodium, another word for salt. It increases your risk for high blood pressure, hands down, which then increases your risk for heart disease and stroke. You see the AHA recommendations here. And the key thing I want to say is know where your sodium comes from. It is sneaky, it is in everything. And when we start making processed foods that are low cholesterol, low fat, right? How do they attract your taste buds to that food? It has to be substituted with some other tasty product, whether it's a sugar or a salt. So if you turn that packaging around and you look at the back and you see sodium and you see 400 milligrams, 500 milligrams, God forbid 1,000 milligrams that may be in something like a noodle package, right? That we may have all eaten when we were in our college days and living from penny to penny. Yeah. Or currently, right? When you're in a neighborhood that only has a bodega for food, right? And everything is packaged and dry goods. That may be the only soup you have, right? Because if you have soup in a can, you can at least empty that out into a strainer, rinse everything off with water, and then add a cup or two of water to whatever leftover vegetables or beans are in that can and make your own reduced sodium soup. You can't do that if it's in a box and packaged, right? So we may be restricted in opportunity and resources, but if we start with the knowledge that we should be checking and tracking these numbers, that would help us immensely. So for sugar, sugar is also sneaky. It's in everything and things that we think are healthy, from juice drinks to chocolate milk to energy drinks and sports drinks, etc. So increased intake of added sugar is a major cause of obesity and diabetes across the globe. And you see the American Heart Association recommendations for sugar limitation here. We don't recommend any sugar intake, so technically it should be 0, but if you're going to take in sugar, I happen to like sour straws or gummy bears, which I reserve for when I'm doing long haul running. That's my snack of choice, that and grapes, right? And so I say, I can't do without gummy bears for the rest of my life, so I'm going to relegate it to something, right? A limited portion during some activity. Right? And you may laugh at me and say, oh, the cardiologist is eating sugar. But the point I'm trying to make is that if we try to cut things out cold turkey, right, then that's a fad and it won't last. So weaning yourself off, tapering yourself off, and adjusting things so that you are on the path to perfection, not expecting perfection overnight, that's the goal. Right? Reading food labels carefully, this is a common theme. Whole fruits, right? Whole foods, this is an issue. So when we have diabetic patients, they say, well, I am eating grapes and I am eating strawberries. Well, I don't want to say there's fruit that's better than others, but there's certain fruits that have more fiber than others and are longer lasting forms of fuel and natural sugar. And those are fruits with a skin. So for example, a pear, an apple, right? Those are fruits that I would advise, particularly if you have diabetes. Those are fruits to choose rather than fruits such as pineapples, strawberries, and grapes that are high in simple natural sugars but don't have as much fiber. Blueberries are another good example of fruits that are recommended, have fiber content, other vitamins and minerals, and are good for our diabetic population. With regard to drinks, right? Water, water, water. Water is the key. Water is the source of life. Most of your body is made up of water. Most of the world is made up of water, right? So water is primary choice. If you say, I can't drink another drop of water, it is boring to me, my body, and my taste buds, I need something else, try sparkle water or fruit-infused water over going to a juice drink, and definitely over going to a soda. Why is that? Because I'll give you a tip and a trick. There's 4 grams of sugar in a teaspoon. So if you're drinking, let's say, a fruit juice with your breakfast, and you have 1 glass of that fruit juice, I'm not going to choose a brand name, I'm not going to say what type of juice, but any juice drink, it has about, on average, 30 to 36 grams of sugar in 1 glass of a juice drink for the morning. So if you divide that in 8, 9, it's anywhere from 8 to 9 teaspoons of sugar in that 1 glass you had for the morning. So what I say as a challenge, go home, try to eat 9 teaspoons of white granulated sugar. I hope nobody goes home and tries that, but I did because I practice what I preach, and my, a patient once challenged me and said, haha, you're telling me to do that. Have you ever done that? And I did. I couldn't make it past the 2nd teaspoon. It's just so clawingly sweet, and your mouth is just full of sugar and tackiness, but we drink it. We drink it every day. And so I want you to think about that. 4 grams of sugar to a teaspoon. Next slide, please. Fats. So there was this whole fat wave. Oh, everything should be low fat. And then we started adding salt and sugar to all the low fat substances and packaged foods on the shelves, and the low fat options turned into unhealthy options again. So if we want to substitute fats, how do we make that choice wisely for ourselves without adding additional products that are harmful, such as salt and sugar? So we can choose fatty, oily fish. We can choose nuts over chips, especially if you're a ruminator when you're working. I tend to ruminate, and I like crunchy things when I'm working. So carrots and nuts are a good option over crunchy things like chips, for example. Healthy oils. So healthy oils, you don't want processed oils. You want oils that are low in saturated fat. And I have examples here, but the most common that I think almost everybody knows of is olive oil. Grapeseed oil is much less commonly known, but if you're in an area that doesn't carry olive oil, look for avocado, canola, or grapeseed. Next slide, please. I want to leave some time for questions, so I'll just try to get through this at a more efficient pace. The other thing you can do, in addition to knowing your numbers, watching the labels, adjusting your food intake and food choices, staying on the periphery of the grocery aisles instead of the center aisles, is get moving. And what does movement mean? There's different types of movement. There's moderate and vigorous types of movement, but in general, right, you should be getting about 150 minutes a week. So if you break it down over 5 days, it's only 30 minutes a day. And if we're continuing our pandemic lifestyles, most of us, right, have started doing some sort of hybrid of walking, cycling to work, or walking more, getting off earlier at an earlier bus stop, or getting out of the subway earlier, or not even taking the subway to avoid recent events recurring with us being there. I don't know how many people live in the city in New York, but it's getting a little dicey. So if you're walking instead of taking public transportation, right, think of these numbers and you can break them up: 15 minutes, 30 minutes, 75 minutes, vigorous activity. What's vigorous, right? Singles tennis, running, right? Anything where you can't complete a sentence without getting short of breath puts you in the moderate to vigorous activity of exercise. Gardening is exercise, but you can talk and sing without getting short of breath. So that's light form of exercise. Build your muscle. Don't forget, particularly women, right? We tend to have lower muscle masses, and then that puts you at risk, especially if you're carrying too little weight for your frame, that under BMI, that low BMI, that puts you at risk for osteopenia and osteoporosis. So at least 2 days a week, weightlifting to get a little bicep, tricep action going, hip flexors, right? It's called the get up and go. If you have to do the little heave ho, trying to get yourself out of the chair, no good, not a good sign, right? That means you've got your proximal muscles in the hips and the thighs that are a bit weak, right? We need to build those up. And motivation, right? Me telling you this may sound motivating, but in 20 minutes, when life kicks in, right, we're all gonna say, I don't have time for that today. So get yourself a buddy, your family, your friends, your religious centers, your community centers, tap someone to be your partner in this, and they will help motivate you when you don't feel motivated. And then you in return can motivate someone when they don't feel motivated, unless you like to do this alone. And in that case, Godspeed, give me some tips and tricks on how I can do that. But most of us do better with a partner. And research has shown that when women exercise with other women, not only do you last longer, but your performance is better. And I'm a runner, and that's proven in the running world, right? When you find a pack of women to run with, you run faster, you run longer, your form is better, you get more enjoyment out of your activity, and you have a better finish. So for all those runners out there, there's a healthy tip and trick. Next slide, please. If you are smoking, there's nothing else I have to say except stop. There are many, many ways to quit. We have patches, we have gums, we have inhalers, we have over a dozen ways to help you quit. And that doesn't mean going from smoking cigarettes to vaping. All inhalants are toxic to the heart, lungs, and brain. So if you're inhaling anything, that should stop, unless you're inhaling albuterol for asthma, right? Or on COPD medications, right? But all jokes aside, right, any toxic inhalants are going to increase inflammation in the body, and it increases deposition of plaque in the body, and it does damage the blood vessels at the heart and lungs, as well as the brain. Next slide, please. I believe we should be on our last slide. Cut back excesses. So excesses, what are excesses? Alcohol, social media, screen time. All these are excesses, right, that can cause both physical and mental damage, right? So excesses in alcohol can make you prone to development of diabetes, can derange your blood cholesterol, can damage your liver, can also cause heart failure, alcohol-induced heart failure. And then screen time, right, social media, it is great for its purpose. But if we find ourselves spending excess time with the social media, in the screen, on the tablet, on the cell phone, right, that can exacerbate symptoms of depression, anxiety, isolation, loneliness, what the young kids call FOMO, right? I'm afraid that I'm being left out and my life is not as good. Comparative analysis to the next person, right? We don't really know how that next person's life is going. We just know what we see on the screen, right? So I would advise, right, cut back on those excesses. And the last slide is the mental health component, right? You cannot have a good overall well-being, sense of well-being, physical well-being, emotional well-being if we don't manage stress, anxiety, depression, panic disorder, bipolar disorder, etc. Right? Stress will affect both your mental and your physical health. It will exacerbate if you have existing anxiety or depression. It will contribute to making it worse. If you don't have those conditions, it can bring about feelings of anxiety, panic, and depression. So physical manifestations of stress are listed here on the screen, but it's not just in your head. That is not the case, right? Anxiety can make you feel chest pain can make you feel like your stomach is in knots. It can block up your intestines. Paralytic bowel is a real thing. You can get constipated, or you can have irritable bowel and have diarrhea. You gain weight, particularly in the belly area, because your cortisol is all out of whack. These are hormone-driven changes, right? So the stress is not just, oh, well, I'm feeling like this on edge. No, that's not just your feeling, right? Your hormones, your adrenal glands are producing all of these stress hormones that are affecting almost every organ system in your body. So if we neglect to manage our stress and manage our mental health, then we are also neglecting our physical health. And on that note, I do believe it is the end of the presentation. Yes, fantastic. Thank you so much, technical support. And if we do have time, I'd love to have some conversation going.
Thank you so much, Dr. Brown. Your presentation was phenomenal. We really appreciate the time that you gave us here today. We actually have a comment in the chat that says, Dr. Brown, you are so motivating. Someone needs to clone you and send you throughout the world to spread the word.
Oh,
Love your presentation. So with that, we do have some additional questions.
Yes.
Couple of them are, first one is, I've heard that too much carbonated sparkling water isn't good for you. Is that true?
There were some studies talking about calcium, leaching, etc. But again, just like anything in life, right? Excess amounts of one thing is not good. Just like if I say water, 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 right? Water loading yourself can reduce your sodium levels, which then can make you prone to having a seizure, right? That's excessive hyponatremia due to overload of water in the body, excess water intake. And that is a condition that an endocrine doctor can manage. I have seen, nephrology has seen. So everything has its place. But yes, if you look on, I'm sure if you look on WebMD, if you look PubMed, right, for peer-reviewed articles that are vetted, you'll probably see some discussion about calcium and bisphosphate and phosphate, etc. But everything in moderation. And when I say everything, don't extrapolate and start talking about butter. Okay.
Okay, so that's kind of feeds into the next question, which is it true that a glass of red wine at night is okay? I hear this a lot, but a nutritionist told me this is not true.
Yes, so it is true if that's what you've been doing since you were 18 in European countries and 21 in America. It is very different if you start doing that at the age of now, right? So there is information that tells us if you start picking up this habit of imbibing in alcohol when you have not been doing this, say you have not been living in Sicily and you've not been, taking in your Mediterranean legumes, beans, salads, and a pescatarian way of living with your nightly glass of wine, and you say, well, 5 decades in, I'm going to start that. Not the time. So it doesn't work that way. So if you haven't had that as part of your usual regimen, then it would not be advisable. Now, we don't advise any alcohol intake, but if you were to drink alcohol on a regular basis, what's the recommendation in terms of limitation? For women, it's no more than 1 in a day. And for men, right, then I don't know if there are any men on the line, but it's a tad more, but I usually tell men no more than 1 in a day, right? Because then when folks go home, they're going to add to that.
Okay, great information. So this is an interesting question. What do you think of getting a virtual imaging scan, which is usually offered as a self-paced service for the early detection of heart disease?
So I always err on the side of evidence. I teach medical students, I teach residents, I teach fellows. So what I say is evidence-based medicine. So if you are in a category where you are at elevated risk for developing heart disease, and that indicates or triggers you to have a screening modality, such as, for example, a calcium score or a CCTA to look at your heart arteries, or carotid Dopplers because your doctor picked up a bruit, which is a whooshing sound that may portend signs of a blockage in your neck, then that is indicated. But if you are at low risk, you have no risk factors, you have no history of premature heart disease, getting that scan would not be indicated. So we don't want to do things that are random and not evidence-based, especially if those scans carry risk. For example, there are some scans, total body scans, that are CT scans. That's radiation. And if you're a woman of a childbearing age, right, and you irradiate your body, then that radiation, right, if you do another scan in another few years, that adds, and then you do another scan in another few years, that adds, right? And then you're getting maybe a chest x-ray and a neck radiation, right? Then those exposures add up. And excess exposure to radiation is indeed a cancer risk. So everything in medicine, just like medications, just like tablets going inside of the body, everything is a plus minus. So the benefit should be weighed against the risk. And if there's minimal benefit and you have a lot of risk, then that test is not indicated.
Okay, that's great. Thank you. So what are some of the non-standard tests or x-rays women should request during their annual physicals or during their visit to their cardiologist?
So straight out the gate, if you're, let's say 30 plus, your blood test should be, right, your cholesterol panel, your hemoglobin A1C, and if you're having any, fatigue symptoms, dry skin, hair is thinning, etc., thyroid function is another good one to check, along with your liver test, your kidney, and your complete blood count. So that's your hemoglobin, your platelets, and your white blood cells. That should be your generic panel, right, for bloods. For imaging, usually there's no scanning of the body that's done unless you have a complaint. For example, if you have asthma, history of asthma, and you have a new cough that won't go away, and you have pain when you breathe, that's pleurisy. Uh-oh, are we worried about pneumonia? And your white count's a little high, then you get a chest x-ray, right? If you have abnormal liver function tests, and those have been high for quite some time, and there's no explanation for that, your doctor may ask you to get a liver ultrasound. Now, let's say you're going to the OBGYN, right, which is a different doctor, or your OBGYN may do general medical practice and is your primary care doctor all in one, then you absolutely should be getting your pap smear. And pap smears are usually about every 3 years. Now, I'm a cardiologist, so please verify with the Gynecology and Obstetric Society. But if you have an abnormal pap smear, then they usually repeat it on an annual basis. If they do find something abnormal, then your doctor may talk to you about another invasive test, and I consider pap smears to be invasive because you are using a speculum inside of the body. Then they might recommend colposcopy, which is an exam where they look at the cervix and may take a sampling of that tissue that's abnormal that they saw on the pap smear and send it for pathology to look for abnormal cells and potential cervical cancer. If you have children that qualify for the HPV vaccine, then that would apply. But I believe those of us who are now 30 plus, I don't believe they're administering to them, to women of our age bracket.
Okay, thank you. And I think we have time just for one last question. Can postmenopausal estrogen therapy help mitigate inherited risk factors for heart disease?
Mitigate? No, and I want to be very cautious about answering that question because that is extraordinarily individual with you and your either OBGYN or endocrinologist and or primary care doctor who's managing that. But estrogen supplementation in and of itself can also pose risk. So again, that's one of those key things with regard to menopause and the cycle of life for women. Supplemental estrogen can be both beneficial and carry some risk. So going over that scale with your doctors who are managing your hormone replacement therapy is essential.
Well, this has been so incredibly informative. We are really appreciative of your time and your energies toward this presentation. Apologies again for all the technical difficulties.
That's okay. That's okay.
Yeah.
We got through it and we hit all the high points. So success.
Yes. Thank you so much. So we will be sharing the recording of this video, and we will be sending out a survey afterwards. So thank you so much, everybody, for attending. Again, thank you so, so much, Dr. Brown, especially for covering so last minute.
You're welcome. I see some questions in the chat, so if it's available offline, I'll take a look.
That's great. We appreciate that. Thanks so much, everybody. Have a fantastic day and a great weekend. Bye-bye.
Thank you.
Thank you.